magnesium, super high yield molecule for us to know. We have seen the slide in the section that we discussed toward the points. We said that magnesium helps stabilize the membrane by sitting in the calcium channels and blocking them because it directly competes with calcium. And that is illustrated here, where they're both divalent cations and they can both sit in that calcium channel. Magnesium also serves as a cofactor for the sodium-potassium ATPase. I'm sorry, not sure what's happening there. Magnesium also serves as a cofactor for the sodium-potassium ATPase. The sodium-potassium ATPase is critical for the restoration of normal intracellular and extracellular potassium levels. So what was the problem that we said occurs in digoxin toxicity? Well, we blocked the sodium-potassium pump to the point that we flipped around the normal intracellular and extracellular concentrations of sodium and potassium. We accumulated sodium inside the cell and potassium outside the cell. Giving magnesium not only helps stabilize sodium conductance, giving sodium not only stabilizes excess calcium conductance, but it helps restore normal intracellular sodium and extracellular potassium levels because it is a humongously important cofactor for this ATP pump. We need to give magnesium to get that pump going to restore normal intracellular and extracellular sodium and potassium levels. Okay guys, last question here. This is something you already know because we've mentioned how beta-adrenergic signaling in myocytes and vascular smooth muscle cells works. All you have to do is remember the normal physiology of beta-adrenergic stimulation and think to yourself, what are some bad things that could happen if I block these receptors excessively? So our question is, what are the toxicities of beta blockers? The toxicities are impotence, the asthma exacerbation, cardiovascular problems such as decrease in heart rate, AV block, CHF, and CNS depressions, such as increased sedation and problems with sleep. All of these listed on this slide were discussed in the slide about beta blockers. Remember, the stimulation of beta-2 receptors causes vasoconstriction, but we are blocking beta-2 receptors, so we get excessive vasodilation. Beta-2 receptors are also responsible for bronchial vascular smooth muscle cell relaxation, and we're blocking that component so we can get constriction of our airways, and for someone that's an asthmatic, that is a particular problem. You can get exacerbations of asthma. The impotence is the most high yield on here because people do not like being limited in that area of their life. Again, this is the beta-2 blockade effect in which we're impeding vascular smooth muscle cell relaxation, in addition to the sympathetic component of ejaculation. So these people are unable to get an erection and unable to ejaculate. You better believe that they're going to show up at your office. That is because you need to vasodilate the vessels that are providing the corporal penile tissue. If you cannot vasodilate, you limit the ability of that organ to be engorged with blood. Now, the cardio element of beta blockade is due to a decrease in cyclic AMP. Cyclic AMP is necessary for increasing intracellular calcium and increasing the rate at which the channels that are responsible for our funny current open. So the bradycardia, the AV block, and the CHF are all results of the fact that we have blocked the beta receptors and caused the inability of us to increase our cyclic AMP. We know that an increase in cyclic AMP increases the ability of us to open calcium channels that are responsible for our contractility, and then it also allows us to open more of our funny channels, which is responsible for our heart rate. Well, we've given a beta blocker and decreased both of the calcium conductance and the sodium conductance responsible for our contractility and heart rate, respectively. That means we get a slow heart rate. We could potentially decrease calcium conductance within the AV node so bad that we can actually lead to acute congestive heart failure. Now, what about the effects on the CNS? Remember, the reticular activating system is particularly important in our ability to sense that we are alert and awake. This has a very strong sympathetic nervous system component. You block the beta-adrenergic component, then you feel tired. And the sympathetic nervous system is also responsible for slow wave sleep. You knock that out, you completely alter someone's sleep cycle. So if someone has these side effects, you can guarantee that they're going to come to you, because these are all incredibly inconvenient, and then potentially life-threatening events. Alright, time for us to test ourselves with a question. So we have a 57-year-old man with a medical history significant for angina and hypertension. He presents because of increase in angina. So he uses sublingual nitroglycerin whenever he gets anginal episodes, but over the past year, the frequency of the episodes has increased from once a week to 7 times a week or daily. The patient is currently taking lisinopril. A note in the chart indicates that the patient is allergic to metoprolol, so he can't take beta blockers. Instead, a calcium channel blocker is added to the patient's regimen. This medication has a clinical effect most similar to that of metoprolol. Which of the following calcium channel blockers is most indicated? Okay guys, I know this is tough. I know you're fading over there. We're almost done. But this is the time when you need to boot your brain back up and just apply whatever you have left. So again, we have a middle-aged male with hypertension presenting due to an increase in the frequency of his anginal episodes and severity that he used to be able to treat with nitroglycerin. He's taking lisinopril, can't start metoprolol because he's allergic to it. So they gave him a calcium channel blocker that works just like a beta blocker or metoprolol. This isn't necessarily a question of how to treat someone, but a question of knowing the mechanisms of how a beta blocker works and how a non-dihydropyridine works in a similar way to beta blockers. So the question asks us which one of these following calcium channel blockers is most indicated. Well, we're worried about a patient that cannot take metoprolol, but we want to give them something similar to metoprolol. So to answer this question, we need to know how a beta-1 selective beta blocker, like metoprolol, is similar to a calcium channel blocker. Well, we know that beta-1 receptors are very prominent in the heart, and if you stimulate a beta-1 receptor, you get an increase in cyclic AMP, which leads to an increase in the intracellular calcium. Now we know that if we block calcium channels in the heart, we go straight to a decrease in calcium. So if we block beta-1 receptors with metoprolol, we also get a inability to increase our intracellular calcium and have the same end result as you would with a calcium channel blocker. The only thing we have left is to know which one of these act on the heart as opposed to which one of these prefer the vascular smooth muscle cell. Well, we said that the ones that are the dihydropyridines, or end in DI, PI, and E, are particularly selected for vascular smooth muscle cells. So we know the answer is not nifedipine, not nimodipine, nor amlodipine. Now we are stuck considering the two non-dihydropyridines, diltiazem and verapamil. And verapamil is most cardioselective, so that is our answer, E. Let's go on with one more question here. In the emergency department, an 80-year-old man with an implantable cardiac defibrillator has persistent episodes of ventricular tachycardia despite attempted cardioversion. He's admitted and started on oral amiodarone. His VTAC improves and he is released. However, weeks later he begins to manifest drug-associated adverse side effects. Which of the following signs and symptoms would suggest amiodarone toxicity? Alright guys, so here's another one, and you're going to jump all over this. So the big long vignette comes with the punchline of, do you know the toxicities of amiodarone? Sometimes it is helpful to read the last question first. So before we even read the entire vignette, we could have read this and automatically jumped all over the question. We know amiodarone has a bunch of iodine, so it can cause thyroiditis. Well, this isn't on here, so we struck out. We know amiodarone can cause a hypersensitivity related damage to the lungs. So is this on here? Oh, I see something about a FEV1 FEV ratio on pulmonary function tests. Remember, amiodarone causes pulmonary fibrosis, which means that there's an increase in fibroelastic tissue in the lung. This means that there's an increase in recoil because there's more fibroelasticity. So that first initial recoil on expiration means you actually get an increase in your FEV1, or forced expiration, within the first second. So that does not mean we get a decreased FEV1 FEV ratio. You would actually have an increased FEV1 FEV ratio in a restrictive or fibrotic like pulmonary process. So B is out of the equation. So that is how they're going to get you. They're going to expect you to know the side effects inside and out. The answer we need to see here is E, due to the effects of blocking calcium channels in the gut, which leads to weight loss, in neurons, which can lead to hyperreflexia, and chest palpitations because of the effects of blocking calcium conductance, which can also lead to a reflex tachycardia. Alright, this sounds exactly like a patient I had today. A 55-year-old white woman with type 2 diabetes has the following lipid profile on routine laboratory testing. And this is your lipid panel. A good tip is to go ahead and memorize the values for the metabolic, lipid, and hepatic panels. It will save you exponential amounts of time on your step 1 exam. Trust me. I had many questions where I should have quickly answered, but I had to pause to look up the value. In general, you should say that total cholesterol should be around 200, LDL below 130, HDL around 30 or greater, and triglycerides anywhere from 40 to 140 is normal. As you can tell, none of her lipid panel is within what we didn't want, which makes sense. She has type 2 diabetes, she has probably metabolic syndrome, we don't know her weight, waist circumference, any of that. But it doesn't matter, because that's not what the question wants. The question continues to set us up by saying that, so at one point in time, we start something for her dyslipidemia and hypercholesterolemia. And then, a couple of weeks go by, and we have problems. AST and ALT are within normal limits. Laboratory analysis reveals normal liver markers. But a CK, or creatine kinase, is elevated at 3,000. Then they ask us which of the following medications places this patient at the greatest risk of developing these adverse side effects. So this is a really tough question because all of these answers are related with the cholesterol metabolism that we discussed when we talked about statins and fibrates and all the other lipid-lowering agents. The fact that her panel is normal is very important information. You should be thinking that this woman has myositis, though, due to some sort of cholesterol-reducing agent because her CK is incredibly elevated. We know that statins are famous for causing myositis, and it is the first-line therapy for hypercholesterolemia. Unless there's a contraindication, which we know is not the case in this woman, you know the answer has to include a statin because it is first-line therapy. So you can go ahead and cross out A and B. Ezetimibe is famous for causing elevation of hepatic transaminases when combined with a statin. So this is not in play for us, and we can go ahead and cross out C because the AST and ALT levels were normal. The answer is definitely a fibrate such as gemfibrozil with simvastatin. Remember, the mechanisms here, and you're golden. You can easily figure out the side effects. Statins not only inhibit HMG-CoA reductase, but they also inhibit coenzyme Q10, which means that the muscle will have increased difficulty with its electron transport chain, causing you to switch over to anaerobic metabolism. Causes the accumulation of lactic acid, and then the muscle will start to break itself down because amino acids can be converted to supply the anaerobic metabolism, and they can also insert in locations within the Krebs cycle. You must know the amino acids and where they insert along metabolic pathways. So statins cause muscle damage because they can inhibit levels of coenzyme Q10, which are responsible for transferring electrons between the complexes of our ETC, electron transport chain. When you combine this effect with a fibrate that limits an important fuel source for active muscle, remember, fibrates decrease fatty acid availability, you set yourself up for even further inhibiting the metabolism within the myocytes, and then you can cause muscle damage, and you liberate creatine kinase, which is an isoenzyme within the muscle, and you can detect it on a laboratory test, and it helps reaffirm that you've caused myositis due to combined therapy of simvastatin and gemfibrozil in your patient. Alright, last question, guys. Let's zone in here, go out on a positive note, let's get this right, and take a Netflix break. So, you have an elderly lady with a past medical history of hypertension, hyperlipidemia, and AFib. She presented with nausea, vomiting, and diarrhea. I'm going to circle all of the side effects that seem to be occurring here. We know it's a side effect question because we're in the pharmacology section, so we're kind of cheating a little bit, but let's keep going. For the past 4 hours, everything she says has been a blurry yellow tint. Super buzzword. Your mind should already be thinking about something. Several abnormalities were detected on the electrocardiogram, including T-wave inversion, an increased PR interval, and a decreased QT interval. What is the mechanism of action of the medication responsible for these symptoms? Okay, great. First of all, her EKG is screaming at you with these inverted T waves, an increased PR, and a decreased Q2. First, you have to remember which drug has all of these side effects. Then you need to consider it and recall the mechanism of action of the drug in question. This is how step 1 will be. Instead of just remembering the drug, you need to take it one step further and also remember its mechanism in addition to recognizing the toxicities that will most likely be in your question stem. Even if you do not remember the drug name, some of these things should make you think and come to the answer. Inverted T waves should automatically make you think hyperkalemia. Do you see an option in the answer choices that could cause an increase in the amount of extracellular potassium? Yeah, you sure do. You don't even have to know the name of the drug that we're talking about. You probably already chose E as the correct answer because we're talking about digoxin. All the side effects listed on here should be making you think digoxin toxicity all day, especially the blurry yellow tinted vision and the GI distress, the nausea, vomiting, and the diarrhea. Okay guys, I hope I did a good job because I truly want you guys to understand these concepts so that when your step 1 exam comes along, you're going to dominate it. Please continue with the next section and best of luck.